Hi, and welcome to the next installment of Physical Therapy Management of Older Adults with Hip Fracture. My name is Marcy Harris Hayes, and I'm Professor of Physical Therapy and Orthopedic Surgery at Washington University's School of Medicine. I'll be presenting the recommendations for intervention during the early postoperative period or the inpatient setting. For our first recommendation, based on level 1 evidence, including systematic reviews, one high-quality clinical practice guideline, and a number of clinical trials, we provided a strong recommendation for the implementation of multidisciplinary rehabilitation programs. Older adults with hip fracture should be treated in a multidisciplinary orthogeriatric program. The multidisciplinary orthogeriatric programs described in the literature typically included multidimensional geriatric assessment, stringent assignment to therapies, and intervention team meetings for goal setting and tailoring intervention. Studies found that with the provision of multidisciplinary rehabilitation, this resulted in reduced risk for mortality, higher levels of return to home, and better physical function. Our recommendation relative to frequency of physical therapy, based on level 2 evidence, including clinical trials, patients should be offered high frequency, minimum of daily, physical therapy training following surgery for a hip fracture. In the studies we reviewed, more frequent physical therapy results in shorter length of stay, earlier achievement of functional criteria for discharge, and a reduced rate of falls. Additional research is needed to determine the optimal frequency and intensity of physical therapy. However, there is some evidence to support short but more frequent sessions throughout the day may be more tolerated than longer intensive sessions during this inpatient setting. For early assisted transfers and ambulation, also known as mobilization, based on level 2 evidence, including a high quality clinical practice guideline and one clinical trial, clinicians must provide assisted transfer out of bed and ambulation as soon as possible after hip fracture surgery, and at least daily thereafter unless contraindicated. Early mobilization is associated with better physical performance, less need for assistance with mobility, and a higher likelihood to be discharged home. Although the evidence to support this recommendation is level 2, we gave this a strong recommendation. Early mobilization is an essential component of best practice for older adults with fracture. To perform a definitive clinical trial for level 1 evidence, it would require some individuals to delay mobilization out of bed, which would not be acceptable. Delayed ambulation after hip fracture surgery is not considered ethically sound due to the negative association with immobilization following hip fracture. For aerobic exercise, based on level 2 evidence, our recommendation is that physical therapists may include upper body aerobic training in addition to progressive, resistive, balance, and mobility training in the inpatient setting. In the Mendelsohn study, aerobic exercises consisted of upper body cycle ergometry for 20 minutes a session, three times per week for 4 weeks. This addition of aerobic exercise to standard physical therapy resulted in no adverse events, improved cardiorespiratory fitness, improved scores in both timed up and go and Berg balance. A larger trial is warranted to address the remaining uncertainty due to the small sample size in this study and the need for a longer term follow-up. For electrical stimulation related to quadriceps strengthening, based on level 2 evidence, our recommendation is that physical therapists may use electrical stimulation for quadriceps strengthening if other approaches have not been effective. This is based on 2 small clinical trials with conflicting findings. The study by Braid found no effect, but also had a much smaller dose of intervention than did the study by Lamb. The study by Lamb provided some evidence that electrical stimulation improves mobility and that the effect persisted and even increased after the end of the 6-week regimen. However, the protocol used in the Lamb study implemented 3 hours of electrical stimulation per day. And this duration may not be feasible for patients or for providers. Clearly, more evidence is needed for us to provide a stronger recommendation. So electrical stimulation for pain management. So based on level 2 evidence from one clinical trial, our recommendation is that physical therapists may use electrical stimulation for pain if it is not sufficiently managed with usual measures. Use of electrical stimulation resulted in positive short-term effects, including improvements in pain score and walking ability. But note the patients in this study were all cognitively intact and had suffered a trochanteric hip fracture. And finally, the management of care transition. Poor transitions between care settings are associated with poor patient experience as well as outcomes. Based on expert opinion, our recommendation is that physical therapists should work collaboratively to contribute to multidisciplinary assessment to ensure a safe transfer from the hospital to the community setting. Assessment should identify any ongoing needs of the person and their family or caregiver, and this assessment should be documented and all needs recorded in the patient's transition of care plan with a copy provided to the person with the hip fracture. Before the transition of care, physical therapists should establish that the patient has a safe and enabling home environment. For example, therapists should check that appropriate equipment and adaptations have been provided and that caregivers are supported to facilitate independence. Therapists should also arrange a home visit unless the patient's abilities and needs can be identified in other ways. For example, by demonstrating independence in all self-care activities, including meal preparation while in the rehabilitation unit. And therapists should provide information to all relevant healthcare providers and the person with hip fracture. And a list of the recommended items to include in that information is provided in the guidelines. So that's a brief summary of the intervention recommendations for the early post-acute setting. Thank you for your time, and I look forward to our discussion in the future Q&A session. Thank you.